Thank you, and good afternoon, everybody. It's a pleasure to be here with you. I'm Dr. Lanika Blackman-Carr from our UConn Department of Nutritional Sciences, and it is my pleasure to welcome you here today for this InCHIP talk, where Dr. Stephanie Fitzpatrick will deliver I'm sure, very informative and interesting presentation today. But I'd like to introduce her before we get started. Dr. Fitzpatrick is an associate professor in the Institute of Health System Science and Feinstein Institutes for Medical Research at Northwell Health. Her background is in clinical health psychology and behavioral medicine. Dr. Fitzpatrick has over a decade of experience developing, implementing, and evaluating behavioral interventions for obesity and chronic disease prevention and management in clinical settings and community-based settings. Her work particularly focuses on strategies to combine behavioral and social health interventions to address social needs and promote health equity. She has served as the PI or co-I on several NIH and PCORl-funded grants. Most recently, her work, funded by the National Institute of Diabetes and Digestive and Kidney Diseases, included a natural experiment with a mixed methods approach to evaluate the implementation of the diabetes prevention program in a large integrated health system, as well as Bridge to Health / Puente a la Salud, a randomized trial to test the effectiveness of a combined behavioral and social health intervention led by community health workers to improve diabetes management and related outcomes among racial, ethnic, and socioeconomic marginalized patient population. Dr. Fitzpatrick is the Director of Research, Evaluation, and Strategic Implementation for the ADA recognized Decide Diabetes Self-Management Support Program. She also currently serves on the Oregon Health Authority's Metrics and Scoring Committee, determining statewide population health quality measures, and serves on the boards for Society of Behavioral Medicine and Society for Health Psychology. As we welcome her, I welcome our audience as well. Please hold all of questions until the end, so approximately 1:15. We'll have a formal question and answer section that I will gladly moderate, but you're more than welcome to drop some questions in the chat, and I'll present those as well at this time. So without further ado, I will turn the floor over to Dr. Fitzpatrick.
Thank you so much, Dr. Blackman-Carr, and happy to be here to join you all in CHIP and present some of my work. Actually, some of the work that was mentioned in my intro is what I'm going to be focusing on today in terms of some examples of how do we implement evidence-based interventions for obesity and diabetes in clinical care settings. So just to walk you through the agenda, I'm going to be talking about our recent R01, where we were evaluating the implementation of the diabetes prevention program at a large integrated healthcare system, and it was a natural experiment. And then talk about our Bridge to Health Puente a la Salud pilot clinical trial that also was a nice partnership between a healthcare system and several community-based organizations in the Portland, Oregon area. And then some lessons learned, overall lessons learned in terms of doing these types of kind of implementation science studies, and then certainly open to some discussion and question and answer. So just briefly, for those of you all who are not familiar with the diabetes prevention program, the diabetes prevention program's clinical trial that took place several years ago, probably I think in the late 90s, early 2000s, is when the initial paper started to be published. It was a landmark clinical trial that demonstrated that engagement in a behavioral lifestyle intervention was significantly effective for reducing risk for diabetes among those who were at high risk for diabetes. It actually reduced their risk for diabetes by 58% when compared to placebo, and was also a little bit more effective at the time than metformin, which was the other intervention arm that was tested out. And so since that time, there's been numerous translational studies looking at DPP. How do we get a DPP implemented within clinical care settings, community-based settings? What if we have lay community-based people leading the DPP classes, et cetera? And so finally, what behaviorists have been wanting since forever is the Centers for Medicare and Medicaid Services decided to actually start to reimburse programs and centers for delivering the diabetes prevention program. And that happened around 2018. And so this is just some of the fanfare of that, certainly from the American Diabetes Association as well as other associations. And this map over here shows, so certainly Medicare, kind of covers it for all Medicare beneficiaries. Medicaid, as we know, is state-based, but it is certainly starting to spread across the U.S. And so this map on the right-hand side of your screen just shows the different states that are implementing reimbursement to some degree of DPP. They're at differing levels in terms of what's reimbursed and how much is reimbursed. But either way, still a huge accomplishment for behavioral lifestyle interventions, and that now people can have greater access and reach. So with that movement, and the conversation started certainly in 2016. I think 2017 is when CMS put out their initial kind of thoughts about how this was going to roll out before they actually wrote it out in 2018. So at that time, I was an investigator at the Kaiser Permanente Center for Health Research, and we said, wow, this is going to be huge when this comes on board. Is there an opportunity to kind of prepare ourselves and even think about how to evaluate how this is going to be implemented within our Kaiser region, just because there's still some remaining gaps in the literature. One, how do we do this feasibly on such a large scale? What is the reach and scalability of DPP, both in person as well as the at that time emerging kind of online digital DPP programs? What's the reach and scalability of those, especially among older adult populations, given it's going to be primarily Medicare beneficiaries? And then what's the participant motivation for enrolling and staying enrolled past the 16 sessions? And then there was a certain payment model that Medicare put in place, and is that really feasible? And how is that going to be accepted by various healthcare systems? So we saw a lot of opportunities to really kind of do some evaluation on the implementation of this. So we were funded back in 2017 to really just do almost this observational natural experiment of, a little bit before the actual CMS started to reimburse, and then kind of what happened throughout. I'll give a caveat, and I'll talk about this towards the end of my talk. As researchers, we go in with these really grand ideas and these really nice study designs, and then the real world or the real health system practices steps in, and all of that gets wiped away. And so I'll talk about that in more detail later, but just kind of go with me as I kind of explain our design. And you might say, well, why did you do it that way? And why didn't you randomize? There's certain reasons for that are pretty pragmatic. But just to give you some more details about our setting. So Kaiser Permanente, again, it covers Oregon as well as Southwest Washington. At Kaiser, we refer to patients as really members. They are members of the healthcare organization, so about 600,000 plus members that are served. And of those, we have about 30% with prediabetes, 40% or so with obesity, and 12% with diabetes, and 30% with prediabetes. And then we use Epic as our comprehensive electronic health record. So Specific Aims 2.0, again, lots of changes that happen over the course of time that I won't use my whole talk to talk through right now. But what we ended up doing in terms of this natural experiment is that we wanted to know, one, how do people who decide to enroll in DPP, how do they compare to people who decide not to enroll in DPP, and compare them on weight and A1C over 12 and 24 months. And we actually was able to capture folks for over a 24-month period. And the way that DPP was rolled out at Kaiser was both in a digital format, which I'll explain in a few minutes, as well as an in-person format. And then we wanted to use the REAIM framework just to get a sense of the reach, implementation, and maintenance of the different versions of DPP based on enrollment rates, session attendance, and retention in the program. And then we also did some qualitative interviews with participants as well as with health system leaders about, certainly on the participant side, satisfaction, what was helpful, but on the health system leader side, how do we sustain this? How do we keep offering a program like this to our members? And then lastly, we did some cost effectiveness analysis as well. So at the time, Kaiser was offering a couple of different strategies or approaches to help people prevent diabetes. And so one of those being what I'm going to call throughout the talk is digital DPP, which is really the Amada Health program, if anyone's familiar with them, they are CDC recognized program for delivering the national DPP program. And so it's all digital. You get connected to an online small group format. There's a health coach. They send out a Bluetooth scale where you can capture your weight on a daily basis. They have lessons that you can read that are kind of emailed or sent out to you that you can access. You can track your food and physical activity on the app as well. So it's pretty, engaging, but self-directed to and on your own time. And then there's the Preventing Diabetes program, which Kaiser Northwest had developed pretty much based off of the national DPP curriculum. Participants would meet weekly for 6 months and then monthly for 6 months thereafter. I'm not going to talk that much about the in-person program. I'm going to just primarily, most of our work has been focused on this digital DPP program. And the reason why we really wanted to focus on that for this particular R01 study is because when CMS decided and made the final ruling that they were going to reimburse DPP, they were only reimbursing in person. And they said there was not sufficient enough evidence at that time to reimburse these digital or virtual DPP-based programs. And as we know with the pandemic, there was some loosening of that, right? Because people couldn't go in person and do groups anymore, but it still has not been made official that these virtual and digital programs are considered reimbursable full out beyond the public health emergency that went into place during the pandemic. And then lastly, Kaiser members certainly have access to usual care, which includes some other diabetes prevention as well as weight management classes and services that are made available to them, health coaching, as well as some live webinars. So that's when I put in air quotes kind of our usual care. And then we wanted to look at, the digital DPP versus usual care. So we use a really pragmatic approach. Again, this was a natural experiment, and also because of the NIH mechanism that we were funded under really required the research side of things to really kind of sit back and watch how things happen in real time in real life. And so we could not kind of come in and deliver the intervention. The funds could not be used for us to deliver the intervention or to control many things in terms of how this is being rolled out. It was really just to kind of sit and observe in terms of how things naturally happen. And so the health system, the Kaiser health system, are the ones who actually identified who was eligible for DPP. A lot of this work happened via the electronic health record in terms of pulling people's A1C and body mass or BMI and weight data over time. As you can see there, we started to, the initial cohort of people that we identified started in 2017. And then a DPP was delivered through almost to mid 2018. And then we followed people, like I said, up to 24 months thereafter. Again, all based off of electronic health record data. So the health system sent out letters using the patient portal within the electronic health record. So again, everything kind of real system, real pragmatic. And you can just kind of see a sample there of what the letter looked like. And then within the letter, there was a link directly to the Amada Health program that patients could then click on and go on and sign up to see if they were actually eligible for Amada. And then they can go ahead and start the program from there. There was some thought about in terms of when this began at Kaiser, who exactly are we targeting? Who exactly do we want to recruit? Again, this is 600,000 members. A third of them have prediabetes. There's not enough resources. There's not enough money to pay for everyone to be able to do the Amada program. And so there were some specific kind of criteria that was focused on it. We initially focused looking at 65 to 75-year-olds, and then the age range expanded as the in-person programs came on board. And then also focus on people who had a BMI greater than or equal to 30, so they were in that obesity range, and then people who had prediabetes with a particular interest and focus on people who were at that borderline diabetes in terms of 6.3 to 6.4 A1C. So here is kind of a diagram laying out kind of who was recruited and who was enrolled. So the health system identified a little over 4,000 people who were potentially eligible for the digital DPP or the Amada program. 587 members clicked on that link to join Amada, and that happened within 48 hours of bulk of letters going out. So really, really quickly, obviously a really high interest in being able to take advantage of this program and to get some support and to prevent diabetes. So 549 were accepted and 511 at the end actually enrolled in digital DPP. And then you can see that the rest of them, with a few that kind of dropped out for ineligibility reasons or for whatever reasons did not enroll, we ended up with 3,621 people who were not enrolled in digital DPP. And then just in terms of our analytic data set, for various reasons, some people were removed from the analytic data set. And so we ended up with 472 patients that we observed over time that were enrolled in digital DPP, and a little over 3,400 that were not enrolled as our comparison. In terms of the analysis, because people were not randomized into treatment, again, this is a natural experiment, we couldn't do that, so we used propensity scores, and we also controlled for a number of different covariates that might have been associated with enrollment in a program like DPP, or certainly associated with weight management. And then we estimated marginal mean weights using linear mixed effects piecewise modeling. And we put these knots. So basically, we kind of modeled from the start, the time that they received an invitation to enroll in a program to 7 months, and then we put another knot at 12 months. If for anyone that does obesity research, unfortunately, a lot of times what we see is we see this check mark. People do really well the first 3 to 6 months, and then eventually that weight starts creeping back up. And so we checked our data after everything kind of came in, and we saw that pattern. So we just wanted to actually make sure that we modeled that to reflect the distribution of our data. And as I said before, we also estimated propensity scores and control for those as well, since there was no randomization. So I apologize for the small print here, but here just kind of pointing out slightly differences in age. This is more so, I think, because of the number of people here. In this particular analysis, everyone is between the ages of 65 to 75, majority women that are in this part of the study, certainly majority of women that are enrolled in DPP, as we often see in some of our lifestyle management programs, is majority women. Some slight differences between enrolled and not enrolled in terms of tobacco use history, as well as neighborhood characteristics based off of percentage with high school degree or less, as well as median household income. Those who are not enrolled tend to be on the lower end of those kind of socio-demographics or socioeconomic status characteristics, and then slightly more specialty care use among those who were actually enrolled in digital DPP. So in terms of those who were enrolled, again, 511 total were enrolled. And as you can see, for the most part, pretty good maintenance in terms of people completing 4 or more or 9+ lessons over time in the digital DPP program, and almost 90% that stayed in the program in terms of the maintenance. It's a year program, and Kaiser covered a year of the program for members who clicked on that link and enrolled. So in terms of the weight outcome, so this dashed gray line here is the people who are not enrolled. The black solid line are people who are enrolled. And so as you can see here, certainly some significant weight loss, about on average about 4.7% weight loss among those who are enrolled in that first 7 months or so. Then we start to see a little bit of a creep up as we go over to 24 months. So somewhat of certainly what we're used to seeing, but still really nice in that this was, again, really pragmatic, real world, older adult population, all digital program here, and still got to see some clinically significant weight loss among this population. With A1C, we saw a little bit of a dip in A1C in the first 7 months. There was a significant difference in terms of change in A1C between those who are enrolled and not enrolled. And as you can see, the not enrolled kind of stayed higher A1C above those who were enrolled over time. But there was no significant difference in terms of the probability of developing diabetes between those who were enrolled and not enrolled. Certainly, it's going in the right direction. Those who are enrolled are less likely to develop diabetes, but that was not statistically significant. And then in terms of cost analysis here, so we looked at a couple of different cost domains in terms of ambulatory visits, telehealth or telephone visits, emergency department, inpatient, also pharmacy dispensings. And so you can see here across the time, those who were not enrolled, their total costs, even if you look at 12 months and 24 months, were slightly higher than those who were enrolled. And then when we look at the cost effectiveness of digital DPP, if we just look at the total, everyone, even under some, we did propensity score matching here. So if you're looking at the sample size numbers, you're like, that's a little different than what we saw in the previous slides. That's because we kind of use a slightly different approach when using the propensity scores. But as you can see here that the enrolled people, their follow-up cost was higher. And even though they had greater weight loss than those who were not enrolled, it cost about $82 more to get that additional kilogram of weight loss. So in this case, when we're looking across the whole population that either was enrolled or not enrolled, we didn't really see a cost effectiveness. However, when we look at those that we consider high risk, are those with A1C of 6.3 to 6.4, so they are just like right on the cusp of having diabetes, we do actually see cost effectiveness and some cost savings here, a little over $1,000 here it cost to be able to get this greater weight loss for the enrolled versus not enrolled. So then, as I mentioned before, we did some qualitative interviews. I just wanted to share some findings from our qualitative interviews with health system leaders, just because we were, certainly thinking about what's the sustainability of this. So what's the sustainability of this kind of CMS structure anyways, this Medicare DPP. And so we interviewed a couple of different people, certainly people who were involved in our Department of Health Engagement and Wellness Services, as well as some physicians, some health coaches, our Medicare consultant, as well as other senior consultants from the national Kaiser office, which is located in Oakland, California. And so some of the challenges that were mentioned is that a number of the Kaiser Medicare beneficiaries actually have Medicare Advantage, which is a capitated plan. And so what that means is that if they were to roll out Medicare DPP, there's no additional funding coming with that. So there's no financial benefit or gain, at least in the short term. So it makes it really hard to get staffing, get people trained up, get systems in place, get database systems in place, because you also have to then report the attendance and weight outcomes and things like that back to the CDC. You have to certainly do billing, processing, and everything with Medicare. That's a lot of resources that are happening, but not a lot of investment coming in, just because these are Medicare Advantage beneficiaries. The other thing is about concerns about meeting the CDC requirements, the CDC recognition requirements. CDC, again, requires these kind of regular reports based on attendance and weight and a couple of other, and I think physical activity as well. And so that means hiring and having someone, a program manager, to oversee all of that, making sure that data comes in. So again, use of resources that may not be reimbursed. And then on the provider side, they just didn't know that there was a DPP and that now that's being covered by CMS. So it's also kind of a lack of knowledge and familiarity with the program and how that program is happening out in the community. So Kaiser was certainly supportive because it is a Medicare benefit, certainly supportive of referring members out into existing DPP programs out in the community, but different programs might vary in terms of how they interact with people and engage, and so some providers weren't really comfortable with just kind of doing that blindly and not knowing all the background. And then even though part of being able to get Kaiser members out into available DPP programs out in the community, they use a broker to do this. But again, not quite sure in terms of where members satisfied with their process and where members satisfied with the DPP site. So certainly some challenges in terms of implementing this long term and some things to kind of think through in terms of how to do this long term in this type of large healthcare system. So just in summary from this study, certainly this population health approach to identifying, recruiting, and enrolling eligible patients in DPP was overall successful. As I said, people were identified, and within 48 hours, people signed up for the digital DPP, so a lot of interest there. Certainly those who were enrolled in digital DPP had significantly greater weight loss than those who were not enrolled. And digital DPP was more cost effective than quote unquote usual care, but primarily among those who were high risk for developing type 2 diabetes in the next 2 years. And so really thinking about when programs like this roll out in healthcare settings, being more thoughtful about that target audience, who's really going to benefit, especially if cost savings or ROI is certainly a priority. So now I'm going to switch gears and talk about, now we're going to move to talking to people who already have diabetes. How do we set up a program to support those folks? And also thinking about the social context in which they are living and not just the medical condition as well. So just to give you guys a little bit of a background, for 20 years, the prevalence and incidence of diabetes had been increasing over time across the world and certainly in the US. But interestingly, starting around 2009 or so, we've seen kind of this flattening of the prevalence of diabetes and also this actual decrease in terms of new cases of diabetes over the last 8 years looking at this data here. However, despite that progress, we still have disparities and we still have health inequities. And so if you can see here in both of these graphs, certainly by education, those who have a less than high school education, they are still at the same kind of highest rate of developing diabetes over time. And when we look at race ethnicity, Hispanic and non-Hispanic Black people are still at this constant rate of having a higher risk of developing diabetes over time compared to their white counterparts. Several years ago, myself and colleagues, we took a look at some of our data at Kaiser, and we surveyed people to understand the prevalence of experiencing or having a social risk or a social need. And so we were able to survey a little over 4,000 members. A quarter of them actually reported one or more social risks, that being food insecurity, lack of transportation, housing instability, etc. And then we compared those who had a social need versus not on different diabetes related metrics. And so as you can see here, that those who reported one or more social need were more likely to have elevated hemoglobin A1C, more likely to have a visit to the emergency department or hospitalization, as well as outpatient visits. And they were more likely to have gaps in their diabetes medication refills. They were more likely to miss their refills because sometimes it's food or medicine for this month is the decision that they're trying to make. So with that, we developed this program called Bridge to Health Puente a la Salud, where we really wanted to get an understanding of, there's a lot of focus right now on screening for social needs, which is so important, and really understanding the social context in which people are trying to prevent or manage the chronic diseases that they are facing. But is it enough just to address the social needs, or do we also still need to support people in actual diabetes prevention or diabetes management? And so that's what this particular pilot study was looking at. One, we wanted to see the feasibility of being able to recruit and randomize this medically and socially complex patient population. We also wanted to get a sense of the acceptability of these two different types of intervention conditions, both from the participant perspective, as well as health system leaders, as well as the interventionists. We work with both patient navigators and community health workers in the Portland area. And then we wanted to explore some preliminary effectiveness, looking at some diabetes-related outcomes as well. And so we recruited a little over 100 adults with poorly managed diabetes and one or more health-related social need to a navigation-only arm, which means that we were only focused on addressing their social needs, or to a navigation plus diabetes self-management support arm. Again, this study took place at Kaiser Permanente Northwest, so I've already given you some characteristics about that place, but just to also say that health inequities, yes, it's Kaiser, and sometimes people think like, oh, it's Kaiser, it's great. Health inequities, unfortunately, are still present there as well, particularly among our Hispanic, Latino, and our Black African American members in terms of not reaching the threshold or the target in terms of diabetes management. Our participants, again, were 18 and older. They had a diagnosis of type 2 diabetes, and their most recent A1C was greater than or equal to 8%. We particularly focused on recruiting Black, African American, and Hispanic Latino um, um, participants, both English and Spanish speaking, as well as low income participants. And because Kaiser does not collect individual level income data, we base it off of whether or not the member was covered by Medicaid. And that brought them into this kind of low income status. And then they also had to report one or more social needed screening. So our recruitment process, I don't know how many people are familiar with Portland, Oregon. It is a interesting place. I've been here now 7 years, and so it's certainly grown on me. But oftentimes the stereotype or what you hear about is that there's no Black people that live in Portland. There's no people of color in Portland. And certainly there is a smaller number, but when there's a stereotype like that, people start to go unseen, and means they go also unserved as well. And so we wanted to make sure that we were intentional about reaching out to the community that is often seen as invisible or non-existent in terms of how we approach that. So sending out a letter with my picture on it just to put a face to the name to try to immediately start to build some trust there. We had our staff reflected the participants that we were recruiting in terms of being from diverse racial and ethnic backgrounds, also being bilingual. And we called people late evenings, weekends, because people work during the day, just like we work during the day. We wanted to make sure that we were capturing people who were at high risk and giving them an opportunity to enroll. Also, again, following this kind of pragmatic approach, we wanted to leverage what was already available and what already happening at Kaiser. We didn't want to totally reinvent the wheel. So at the time that we wrote this grant and started this study, there had already been a patient navigator program that was in existence. We had about 30 navigators. I think we have even more now. But the purpose of these navigators are to screen for social needs and connect people to services, whether that be externally in the community or internally within the health system itself. And our navigators have various backgrounds, educational backgrounds, but they're trained in MI and also trained on the different resources that are available in the community. We also partnered with about 8 different community-based organizations. Each of them had their own community health workers because we wanted to go outside of the health system, because oftentimes how we prevent or manage our health happens outside of the clinic walls. And so we partnered with 8 culturally specific community-based organizations and their CHWs. We trained them, did about 20 hours of training about diabetes and diabetes management, and also just research and research ethics. And then we trained them in the DECIDE program, which I'll talk through in a little bit, which is our diabetes self-management support intervention, and then also how to screen and how to help support people and address any social needs that came up during the intervention period, which was 6 months long. And then we also provided biweekly supervision and case management with them. When addressing health-related social needs and tracking those, we did that in 2 ways. So one, we administered a social risk screener called the Your Current Life Situation. We administered that screener at baseline and then again at 6-month follow-up. So when the intervention stopped, and we did this for both study arms. And the way that we kind of thought about, okay, was that social need met or not, is that if they endorse a particular social need at baseline, but not at 6-month follow-up, we made the assumption that that need was met or resolved. That's not a perfect way to do this. I think there's a whole line of science that needs to happen to better be able to track how social needs are addressed and if social needs are met or resolved or not, but that's how we did it in this pilot study. And then the community health workers also had their own case management software that they were documenting specific needs, the referrals that were placed, and then what were the resolution of those referrals. So this is just a visual here in terms of Bridge to Health, Puente, Salud. So in both study arms, people are screened for social needs. If they have one or more and they have the poorly managed diabetes, they are then randomized, and in both cases, they are connected to a Kaiser patient navigator. The Kaiser patient navigator works with them, looks at their social risk screener, and starts to work with them on placing referrals to community resources to address social needs. And that happened in this navigation only arm, and the Kaiser navigator might follow up 1 or 2 times. And the navigation plus diabetes self-management treatment arm, in addition to being connected to that Kaiser navigator, they were also assigned to a community health worker who worked in tandem with the navigator on addressing social needs, but also that community health worker delivered the diabetes self-management support intervention, which is the DECIDE program. And so the DECIDE Self-Management Program is an American Diabetes Association recognized diabetes self-management support program. It consists of 9 modules. The first module is really an education-based module about diabetes and heart disease, as well as different ways to engage in self-management and behavior change. And then the rest of the modules are focused on problem-solving training, teaching people the problem-solving skills, what gets in the way of making behavior changes and how to work through that, how to set goals, and how to reevaluate after you've chosen one solution and then trying out other potential solutions to address the problems that get in the way of managing their diabetes. So here's just our CONSORT diagram from the pilot. We started out with a recruitment pool of about 425 people. As I mentioned before, we randomized 110 people, 54 to the navigation only arm, 56 to the navigation plus diabetes self-management support arm. We lost just a few people to follow up. Unfortunately, we also had 2 participants that died along the way. And then we use an intention to treat in terms of analysis, but here just to give you a sense in terms of who was able to provide follow-up in terms of A1C and also that repeat social risk screener. I should also say that we were caught by, as probably a number of you in your studies, we were caught by the pandemic. We were trying to wrap everything up in 2020 or started to wrap things up in 2020. So that also certainly contributed to some missing data. Here, just the baseline participant characteristics. Just want to point out, as we were intentional about having predominantly Black, African American, Latino participants, as well as those who have Medicaid. So you can see that's the majority of our participants that are enrolled. We had about 14 Spanish speakers. A1C, certainly, poorly controlled, much higher than the 8% that we usually strive for. And if you look at social needs, in both study arms, 70% or more had 3 or more social needs. You can get a sense of the type of social needs that they were reporting across the 2 study arms. So because this was a pilot feasibility trial, we were certainly more focused on these kind of feasibility metrics. One, can we recruit this medically, socially complex population? We did meet our recruitment goal. It took a little bit longer, but we also were able to get some additional beyond what our goal was of 100. We actually recruited 110. We also set a goal of being able to connect 50% or more of our participants to a CHW and/or a patient navigator. And the reason why we set that goal is because of previous preliminary work of what happens is once someone is screened and identified, and then someone goes to follow up and do a call, we lose them for various different reasons. And so we did not want to lose track of people after we knew that they were positive for a social need. And so we really strove hard to make sure that we were connecting quickly and fast the people. So we did pretty well in terms of connecting them to a navigator in both arms, as well as connecting them to a CHW. We also wanted to make sure those connections happen in 7 to 14 days. It took a little bit longer for the navigators, but we did pretty well in meeting that goal for CHWs. Again, there's 9 modules to the DECIDE program. About 40 of the participants completed a mean of 7.4 of the sessions. 30 of them completed all 9 sessions. And then we wanted to at least get A1C data on 80% of our participants at 6 months. And we relied on them going to their home clinic or home lab to get the A1C. We didn't do a great job of that in terms of the navigation arm. But for those who get a navigation plus diabetes self-management support, we hit that goal exactly with 80%. So in terms of preliminary effectiveness, as you can see across the board here, we were able to get, everyone had an A1C at baseline over 8. We were able to get a third or more of them less than 8 at 6 months. Not statistically significantly different between the 2 arms. Certainly as you look at mean change in A1C, it could be considered clinically significant in that it's greater than the 0.5 that we usually look at in terms of reduction in A1C, but that's also across the board and not statistically significant between the 2 arms. Some of the qualitative interviews, again, we did with both participants as well as health system leaders and the interventionist. And I'll just quickly go through these because I'm seeing the time and I want to make sure we leave some time for questions. and that those who were in the navigation only arm, those participants, they said, they really appreciated working with the patient navigator and receiving a list of community resources to go to address their social needs, but they would have liked more follow-up from the navigator. As I mentioned before, the navigators might have did 1 to 2 more follow-up calls after that initial contact, and then that was kind of it. And those particular participants felt like we needed a little bit more in terms of a follow-up after that. For those who were the navigation plus diabetes self-management support, had a new sense of empowerment. They felt more control in managing their diabetes, but at times they wished that their CHWs were able to answer more questions about their diabetes and thought and wanted their CHWs to have more of a lived experience. This particularly came down to questions about medication and how to do insulin and things like that, which we trained the CHWs to not answer questions about medication. That's just kind of beyond their scope. But that's kind of where that comment comes from in terms of that frustration from some of the participants. And then health system leaders, certainly it's an advantage for integrating CHWs onto our care teams. They are more capable of delivering culturally competent care, but there's always, again, that return on investment. How do we do this sustainably? And also, how do we set clear expectations? If we're adding CHWs to the care team, how do we distinguish them from the navigators or the MAs or the nurses or the social workers in this case? And that was similarly what the patient navigators and the CHWs also brought up, in that, they enjoyed working with each other as well as working with the participants, but just having better expectations about their roles and responsibilities and how to distinguish the two. So lessons learned from implementation studies, and particularly these 2 studies. So one, I think to have a bigger impact, focusing on those who are at the highest risk. Certainly with the implementation of DPP, we found in terms of cost effectiveness, we saw cost savings when we focus on those who are just on the cusp of developing diabetes in the next 2 years. And similarly with the Bridge to Health Puente a la Salud, although certainly some complications in recruitment and getting and retaining people in the study, I still think, and I'm still getting people in the community coming up to me saying, when is Bridge to Health going to start again? Or where are you going to do Bridge to Health next? Because it was such an impact. These are people who had not been served before, people who no one asks about what kind of needs do you have? Do you have a place to stay? Do you have food access? Do you have medication access and get services like that? Community engagement is bidirectional. It's not about what the community can do for us. It's about what we can do for them. Certainly that takes a lot of time, but it's so valuable in terms of partnering with community-based organizations. And then implementing with sustainability in mind. And so in both of these studies, I've always been thinking about okay, once the study is done, how do we continue some element of it, if not the entire program? Being aware of and tracking changes in the health system. This is what I alluded to in the beginning. And so there was a number of different changes for both the DPP implementation, especially for the Bridge to Health, in terms of staffing, and there were layoffs, and there were structural changes in terms of different teams and who was doing what. And when those internal health system workforce changes happen, that impacts, right, the ability to carry out the study, but it also has implications for community partnerships as well. And so we certainly experienced that and went through that for both of these studies. And then tracking and close follow-up of participants is important. Knowing what happens with people over time, and then making sure that information is put somewhere that's visible to the care team. So for both DPP and Bridge to Health, we did a lot of data entry in the electronic health record, as well as in the portal, and also in terms of emails, electronic emails to providers to let them know, hey, your patient is enrolled in this intervention. This is what's happening, just so they would be aware of what's going on. And then this work requires time and patience. Health equity is about meeting people where they are, and that is not a one and done, not a quick process at all. Recruitment took, like I said, took a little bit longer for Bridge to Health, because at times people said, I don't have a roof over my head right now. I can't think of signing a consent form and enrolling in a study, or even think about managing my diabetes right now. That is not priority. Priority for me is finding shelter. And then lastly, balance of rigor and respect. I know I've known Dr. Leahy for a long time and did the NIH behavioral randomized control trial summer institute with her. And I just remember getting the drilled in, the randomized control trials, and you got to control this, and this is rigor. But when you go out into the community, and particularly these marginalized communities that are underserved, you also got to be respectful. And sometimes their rigor is going to have to waver a little bit to be able to build that trust and be able to get the data and be able to do the intervention that you want to do. So. With that, I want to acknowledge all of my partners, certainly my co-investigators, my funders, NIDDK for both of these studies that I just went over, the participants, study staff, etc. And thank you all, and I'm happy to take questions.
Well, thank you so much, Dr. Fitzpatrick, for this work and for sharing these really important findings with us. So yes, it's open to all who are with us today to submit any questions via the chat. I see we have one already I'll present, but also feel free to use the raise hand icon at the bottom of your screen, and that will also alert me that you have a question, and you can certainly unmute yourself. But perhaps we'll start with the first one that we have, which says, "Hi, great presentation. I'm wondering what the majority of social needs were and whether they were able to be met in these studies." And so if you can speak to that, that would be wonderful.
Yes, I can. And let me share my screen again. I actually put that slide in last because I wasn't sure if people wanted to see that. But so certainly food insecurity was a high need. Lack of transportation was also a high need. And so here you can see for the navigation only arm, in terms of those people who screened in these areas, and so I have the sample sizes here, this is what we were able to do in terms of addressing that in the navigation only arm. So not 100%. This work is tricky because it also depends on the resources that are available in that community, right? And food assistance, food pantries, food boxes, food banks can only go so far. Housing, definitely limited. I'm actually surprised that we were able to get 35% of people connected to some form of housing. And so here are the numbers here for the navigation plus diabetes self-management support arm as well. Certainly, I think the slightly higher numbers here for some of these social needs probably reflects the community health workers that being integrated in the community, but also connected to CBOs that have programs that address these specific social needs. Certainly, I think help to facilitate addressing some of these needs here.
Thank you. This is certainly really informative because I think this is a conversation we're having across the field about really thinking about social risk and those social determinants of health that really precede or can impede, perhaps enhance, depending on somebody's identity. The ability to engage in these health behaviors that ultimately get us to more favorable either obesity control outcomes or just generally better health outcomes. And so I think that's incredibly valuable. I'm just wondering about your thoughts on the same token on what does it look like in future interventions to really address some of these social risks? I know you said it depends a lot on the partners, but I'm sure you've had lots of conversations and time to think about this. So what would really be effective for addressing social risks, maybe in, food? I think food assistance was one of the places or variables mentioned. So I'd love your thoughts on that.
Yeah, I mean, I certainly partnerships with community-based organizations and making sure that that is embedded into your study design and getting people connected and tracking that and tracking what happens over time. With with food insecurity, right? It's in this kind of episodic, right? It kind of comes, even if we connect people to SNAP. Well, oftentimes SNAP funds only last for those first 2 weeks of the month, and then it runs out, right? And so it's really thinking this kind of longitudinal mindset in terms of like how can we make sure that there's food resources in place long term. And I think that's one of the biggest distinguishments between social needs and social determinants, and that social needs is at the individual level, right? And that adverse social condition. And so we can connect you to a food bank, we can get you a food box to, help you for this temporary part of time. Social determinants is how do we change our policies? How do we make sure we have supermarkets with affordable foods in all communities available? How do we make sure that we have public transportation services so that people can get to supermarkets and get to different farmers markets and things like that, and like the voucher programs? So thinking on this kind of policy system level side, in addition to these individual things that we do, how can we start to integrate that into our research and evaluate the sustainability of those approaches?
Thank you. Thank you. So I'll ask a question just regarding that balance of rigor and respect. I'm wondering if you might be able to share a couple of practical examples of what that looks like within your work to really balance that. Because yes, the field demands one thing, but then there's the reality of doing this on the ground and in real life that you mentioned. So, what are some of the, I guess, concessions in rigor that you've had to contend with?
Yeah, I think, oftentimes in intervention studies, right, we want the intervention to be delivered to fidelity, right? So it's got to start at a certain time. There's a certain frequency of the visits, whether that's weekly or biweekly or however it's designed to be laid out. The DECIDE program, um, um, how it was designed or how it started out was that the sessions would be delivered every other week so that people on the off week would have time to kind of apply the strategies and the approaches learned to their life and then work on some things and then come back and then follow up with the next session. Our CHWs work with people for 6 months. The way we designed it is that as soon as people get recruited and enrolled, they start the DECIDE program immediately. That didn't happen for a number of people, as I mentioned before, because they didn't have a house, they didn't have food. There were other situations that were priority that were happening, and CHWs came back to me and said, we got to get these people stable before we can sit them down and do this protocolized manualized treatment right here. They're not there, they're not in the headspace, and we just got to like focus on their social needs for right now. And so we said, okay, let's tailor it based on when people are ready to start. Are people willing to do back-to-back sessions? Does that work for them? Are people willing to do every other week? And so, how the intervention was rolled out differed across people, whether or not that might have had impact on findings outcomes. We haven't looked at it in that way and did all those different iterations. But certainly, right, that was not the protocol that we had set out to do, but we had to make that switch to be able to meet people where they are and respect that that's not where they were at that time to be able to start a program like that.
Makes perfect sense. You have to get the necessities taken care of first to really be ready for that. And just a comment here in the chat around policy change that's happened at the level of the USDA and the ability to use SNAP and WIC electronic benefits for online groceries, which can help improve healthier eating, but it does require digital literacy and nutrition literacy as well, but can be part of, breaking down the barriers to getting healthy eating and hopefully stretching that food dollar as well. So thank you for that comment. It's nice to see how some of our modern day things are able to really address some of these contextual issues and risks.
Yeah, and I'll just say I'm a co-investigator right now with a really smart guy at Beth Israel BIDMC, who was doing a trial looking at the DASH diet and connecting people to DASH foods using, I think, Amazon Fresh and Instacart. And so they're working with a dietitian to pick out the groceries, and they're also getting recipes and things like that. And then they're having them delivered to them because they live in food deserts in the Boston area, to then be able to, one, address the food insecurity part, but then also in terms of connecting them and creating access to healthier foods. And so we're studying that now in terms of the impact of that intervention on blood pressure management. So.
Stephanie, if I can, Monica, I have a quick comment and question. Okay, thank you. Stephanie, fantastic talk. It was excellent. I really enjoyed hearing about your important work. And I just wanted to talk a little bit and hear kind of some thoughts about your first study. And I, it's wonderful to be able to collect these cost data because that, of course, informs decision making. And really interesting that you were able to show that the people most at risk are the ones that are showing that greater cost effectiveness. And I would love to just hear a little bit more about the OMADA program. So, I think we're all doing a lot of work in the digital health space. To that end, I was just curious to hear about the program and, thinking about the impact in terms of both weight loss and cost and all of that. So I would love to just hear a few more details about the OMADA program. I haven't seen it intimately myself. So if you could just speak to that.
Yeah, sure. I can try to. It's funny. We just met with them for something else yesterday, and I will say, I don't know all of the digital programs, but I would say they are probably one of the most prolific. So they've got a ton of papers. that are out there. I know they just finished up their first RCT, probably about 6 months or so ago, if not a little bit longer ago, and I think that's published now. But it's really, if you think about the national DPP program, it's certainly aligned with that. They train their coaches in behavior change and motivational interviewing. From my understanding, because of all the tracking capabilities that are available in terms of tracking weight, tracking food, tracking activity, the coaches see that information and can then kind of come back to the individual participant and help them kind of problem solve or think about ways in terms of making changes. But then there's also this group part too, and I believe people get put into groups based off of geographics, but also some other characteristics in terms of things they might have in common, like sports or having kids or different things like that. And so they're kind of put into these online groups, and there's like a kind of a blog communication type of board in terms of how they interact. The coach might throw out questions and things like that for the week based on the lessons. Each of the lessons reflect the 16 DPP session content, even though they are designed to be read or went through within 10 minutes. So a little bit different in that sense because it's all kind of self-directed. What else can I tell you? Does that help, Tricia? Okay.
Yeah, interesting to hear a little bit about the group piece. Oftentimes the digital interventions are more individual, and so that's interesting. And I'm always curious as to how that works, and engagement and all of that when combined with digital. So yeah, thank you.
Thank you for that question, Tricia. Any other questions out there? We do have a few minutes left. I think I've had mine asked and answered, so I won't belabor any points with my own individual interests. But unless there's any further questions out there, I definitely want to thank Dr. Fitzpatrick for joining us for this InCHIP lecture. It's really been a pleasure to hear about the work that you're doing and the innovative ways that it's addressing and considering social risk, really in a pragmatic and real life setting. And so wishing you best of luck for what may come next. But thank you so much for joining us today. It's really been a joy to have you.
Thank you so much. Thank you for inviting me.